Well, thank you for that very kind introduction. It's always great to be in the shadow of Mount Shasta up here in Northern California. What a beautiful area it is, and what a great meeting that is put on here by the Con crew. What we'll speak about for the next few moments is how to make our health better and how to prevent heart attacks. And it's more on a primary prevention scale than a treatment. Let's wait for this disease to occur and treat it scale. Here are my disclosures that have been mitigated. And what we'll like you to go away from is understand the main drivers of cardiovascular disease currently, review the importance of lifestyle, and recall ways to incorporate lifestyle in your habits and your patients' habits. So do we really need to reduce cardiovascular risk? You just heard two great talks. One, we can prevent it with giving SGLT2s and GLP-1s, and we can find it early with a CT angiogram. So do we need to reduce cardiovascular risk? We know it's gone down tremendously. You know, the peak of cardiovascular death in this country was in 1970, just before this graph started. This just came out about 18 months ago, showing how we had a tremendous reduction in cardiovascular mortality until 2010. In 2010, of course, we've stayed very low, right? Not quite. You can see that part of it here was the COVID in the last few months or few years from 2019 up to 2020. It was certainly played a role there. But look at this area in here. We have lost about 60% of our reduction in cardiovascular mortality that took 6 decades to achieve. This article did not go into why we lost that, why we've lost that benefit in just 10 or 15 years. But if you look at this article from The Lancet not long ago, and this is for worldwide, not just for the United States, of course, but they look at the global dailies, which is the disability adjusted life years. So if you die, you don't have a daily, or you weren't there to enjoy your life, or if you have a disease, you're not there to enjoy your life. And they divided up 88 different risk factors into 3 categories. One was behavioral, which is mainly things like smoking and such, and that's gotten better. One was environmental, occupational. The pollution has gotten better. Some of the noise pollution, the air pollution, et cetera, has gotten worse. But certainly the plastics have gotten worse. But overall, it's improved. But the metabolic risk, which is 5 of the top 8 risks I've listed here, you can see are significant. And those risks are systolic blood pressure, fasting blood sugar, body mass index, you heard about this morning, lipids, and kidney dysfunction. And all these lead to a lot of heart disease, and they're certainly doing it with us. And this looks like this is the primary issue now in the United States also, is why we've lost so much of our mortality reduction that took so long to gain. And if you look at the prevalence of this new syndrome, which came out a few years ago, the cardiovascular kidney metabolic syndrome, which is trying to get at the idea of everything that happens as we have a poor lifestyle. Blood sugar goes up, weight goes up, exercise goes down, stress goes up. And these were patients that were mean age 47, and they divided the country up with some very fancy statistical methods of saying what percent of our patients have CKM syndrome. Well, only about 11% had stage 0, which is good. Dysfunctional adiposity was a quarter. Metabolic risk factors and moderate high CKD issues were chronic kidney disease was about half. And then about 15% of the patients have very high-risk CKD or high-risk CVD risk, or they actually have coronary disease. And remember, these patients were 47 years old. Not that we would term that very old at all. But you can see that if you were a man, your risk was higher, 17%. Black African Americans, 19%, had stage 3 to 4. And if you're over age 65, the risk was over half of those patients. So 90% of U.S. adults are at significant risk for cardiovascular disease. So we don't need to find patients at risk. It's everybody. And you just heard a great talk from Dr. Budoff on CCTA. One thing I just wanted to add was that this was a CT coronary angiogram study done in patients that were low risk, asymptomatic, And 49%, almost half of them, had plaque on their CCTA, including 16% of them that had negative calcium scores. And about 7% of them were high-risk plaque. The Dr. Budoff mentioned briefly at the end that they have vulnerable plaque, more lipid-rich, more likely to cause plaque rupture. And this was in 74% of these patients had a 10-year risk less than 5%. So again, people have disease, and although it's preclinical, it's asymptomatic, they certainly have disease. Now, can't we solve this cardiovascular disease problem by just spending some more money on it? We heard if we can spend some more money on GLP-1s, we may be able to take care of it. If you look at this very provocative study that came out a couple of years ago on healthcare expenditures per capita versus life expectancy. And here on the x-axis is life expectancy on the bottom, and then here on the y-axis is healthcare expenditures in 2019 dollars in US dollars, thousands. So you can see as the index here, the US, we're doing great. We have a 11,000 per capita we spend. Our lifespan is 77 years. So that's not a bad return on the investment for $11,000 per capita. However, if you look at a country that spends half of what we spend, Australia, 5.5 thousand, they have a lifespan of 83 years. And if you look at a country that spends 1/10 of what we spend, Chile, they have a lifespan of 80 years. So it's not necessarily how much money we spend on it. It's how smartly we spend our money, obviously. So how do we spend our money for prevention? Well, here are the 13 CPT codes that reimburse for cardiovascular prevention. And there are things that we all hopefully do every day, such as lifestyle screening, diet, physical activity, smoking, lipids, blood pressure, etc. And you can see these numbers are not overly impressive. These are not in the thousands. There's not a K behind these numbers. So you get $25 to $30 for doing a weight and adiposity assessment, etc. And the average of this is about $25 or $30. And I frequently tell patients, I'm seeing you today, and I'm talking to you about how to prevent heart disease, and Mayo gets paid X. I work at a place where we're all on salary at Mayo Clinic. And I say Mayo Clinic's paid X. But, if I'm trying to prevent your heart attack, but if you were to come back next Monday and had an acute MI, as you can see, with the DRG 248, which is a PCI with non-drug-eluting stent with major complication or comorbidity for an MI, then Mayo gets paid 1,000 times X. So we're very interested in preventing disease, but we are so busy treating disease, and the reimbursement is so high for treating the disease because it's very expensive, that's how we spend most of our time doing it. So I try to convince patients it's really up to you. You need to prevent this disease because you don't, this idea of CV prevention being one doctor or one nurse practitioner or one provider in one room for 1 hour with one patient is a thing of the past. It needs to be one provider in one room for 1 hour with 1,000 patients. We need to figure out how we can do that to reduce disease. So why can't we just wait until the disease occurs? Can we just treat patients then? We know we're very good at that. Well, how many deaths, cardiac deaths, do we prevent with primary versus secondary prevention? And just to be clear, primary prevention is to prevent the disease, prevent the cardiovascular disease, the coronary disease. And secondary prevention is wait for the disease occur, and then we prevent it. Then we give the statin, then we put the stent, then we do whatever else we're going to do. Well, here about 370,000 patients, 3 different databases in Sweden, UK, and USA, you can see that the primary prevention will prevent about 80% of the deaths. We only prevent about 20% of the deaths with secondary prevention. And that may be surprising to some people. And it's always surprising how little confidence patients and providers, especially patients, have in the life-saving ability of primary prevention. They really think, hey, doc, just let me, I saw my neighbor. He had a heart attack last week. He went to the lab, they put a stent in him, he's back on the golf course. He looks great. But they have so much confidence in the life-saving ability of secondary prevention. So what's the problem with that? Well, there's a thing called sudden cardiac death. The classic teaching has been that sudden cardiac death is the first symptom in about 20 to 25% of patients. And so 1 out of 4, 1 out of 5 are dead within an hour by the definition of sudden cardiac death. And we can't really do much for those patients in general. But recent studies have shown that 10% of all SCD occurs under age of 50 years, and that 90% had no clinical diagnosis of coronary disease. 90% were men. That's a shocker. Men love to deny they have any illness, and that way they don't have to worry about it. And I got to admit, women are they're catching up though. 65% had at least one risk factor, and 44% were clearly due to coronary artery disease. So this is a big deal. And where is it? The bigger deal is in third world or emerging economic nations. The majority of heart attacks in this country are in the over age 65 group. In other nations like the BRICS, the Brazil, Russia, India, China, South Africa, their average age is about 52 for their heart attack. And you give someone a heart attack who's in the 52 in the workforce, that's a huge economic disincentive. And that's what I'll be going to Davos next January to talk to them about this exact issue, that they're going to need to start to reducing cardiac disease before it even occurs rather than to wait because it's so expensive. Now, there's also the health belief model. And just very briefly, that's if patients fail to perceive that one habit is risky or less severe consequences, they have no reason to modify it. Say, it doesn't matter. It's not me. It doesn't count for me. Well, this is the bestsellers from the Amazon cardiac health webpage a couple months ago. Things that are wonderful articles like The Great Cholesterol Myth, How It Doesn't Matter, The Paleocardiologist, Eat All the Fat You Want. Dr. Seby's book's actually pretty good. He talks about how to eat healthy and things like that. A Statin-Free Life, and then this is my favorite, the cayenne pepper to prevent heart disease. But do patients think they need to change their lifestyle? They read stuff like this. These books are bestsellers because people buy them. They're not because they just happen to be on the front page of Amazon. Do smokers think they need to change? About 64%. Do they think they can change? This is the smoker themselves. Only 40% think they can. Do risky drinkers think they need to change? No, they really don't. Do unhealthy eaters think they need to change? Well, 3/4 do, but less than half think they can, and GLP-1s can certainly help that. And then lack of physical activity. 73% think they need to do better, but only 52% think they can. And remember, all the GLP-1s, like all the statins, when they're approved by the FDA, they're approved in addition to what? Lifestyle, exercise, and healthy diet. The two most overworked words, or the single most overworked phrase and misunderstood phrase in medicine. Has any of you ever said it? I used to say it all the time. I want you to get plenty of exercise and eat healthy. And they'd say, yes, doctor, I will. So I tell people now, since COVID, you have a new job, and it's called Your Health, because no one else in the world really cares about your health. I mean, Mayo Clinic, we care. UCSF and Dr. Khan and his crew care about your health, but we're so busy treating the illness to try to keep you healthy, we don't really have time. And the health really needs to start in the pulpit, in the schools, in the barbershops, in your home, not in our offices. So what can you do to reduce cardiovascular risk that takes seconds or minutes a day? I mean, this is important to all of us. We're all so busy. Everybody is overwhelmed with the things we need to do in a single day. So the metabolic risk, blood pressure and kidney dysfunction, what can you do there? Well, blood pressure is an issue. What percent of people have high blood pressure? And this is always appalling to me, and I'll tell you why in just a moment. But if you look at at age, 30% of patients in their 20s to 40s have high blood pressure. Once you get to age 55, there's 70%. And goes higher, almost 80% when you get to 75. And if you look at all ages, who's aware? Only about 60% of patients are aware they have high blood pressure. Only about half of them are treated, and only 20% of them are controlled. And women are getting higher rates of uncontrolled starting at age 61. They have higher rates of not controlled blood pressure than compared to men, and that's not something they want to be ahead of men at. The reason this appalls me is we had a hypertension specialist at Mayo, Sheldon Sheps, that some of you may know, and he was like JNC3 or one of these early heart blood pressures. And when he was at Mayo, he did a very intense Mayo Clinic community, Olmsted County, where we live, education project, and a project to go out and find the hypertensives, educate them, treat the hypertensive, control the hypertension. At the beginning of that study, the control rate was about 20%. And after 2 decades of his life, guess what the control rate was? 20%. It didn't change a bit in a place where I think we have pretty good health care. So what is the guidelines starting to say? Guidelines are starting to say that the automatic blood pressure cuffs are so accurate that should be part of the rationale that you use to treat people and ways to follow them. If they have a normal R-to-R interval, they're great. The automated cuffs, I happen to like the Y things. It tells you actually on here what your goal should be in green there. It graphs it, it emails it, it averages it, and sends it to your medical record. So get it. And the guidelines are variable on how often they say to check it. Some say check it 1 week, for 1 week a month, twice in the morning or twice in the evening. Others have said just check it randomly 3 or 4 times a week. I'm not sure there's an answer, but check it. And if you can't figure out how to make this work or hook it up to your phone, ask your 5-year-old granddaughter, and she will do it in about 30 seconds and think you're so cool. Oh, granddaddy, oh, that's so cool. You're so techie, you know. What can you do to reduce CV risk to take seconds or minutes a day? What about fasting blood sugar, BMI, LDL, the nutrition, the more classically thought of nutrition things? It was mentioned earlier, the Mediterranean diet. This is the most common diet we give out at Mayo Clinic at all 3 sites and our health system. It really emphasizes the extra virgin olive oil, the nuts, the fruits, the vegetables, legume, very few ultra-processed foods, 3 a week. And we'll talk about how many we're eating now in this country. A little bit of dairy, a little bit of red meat. And it's quite controversial, but a little bit of wine, small amounts. If you look at the dose response curve for ultra-processed food, servings, and cardiovascular mortality, it's really impressive. You can see that once you get over about 2 servings a day of ultra-processed foods, on average, the mortality, this is the hazard ratio for cardiovascular mortality, goes up about 75%. So you should eat less than 2 servings a day, and that's what we recommend to patients. How many do we eat in this country? Over 7, unless you're younger. Our kids, our teenagers, our college students, and early 20s are eating 8 to 10 a day. And it's not a good thing because it's very pro-inflammatory. And once you start eating these things, I agree with what was said earlier, you get addicted. You really cannot get away from them. And they're so easy and so easy to do. And if the NOVA, which is Dr. Monteiro from University of Sao Paulo in Brazil, where I've been and visited, and I really commend him and his crew for getting this going. The NOVA classification, which doesn't stand for anything, it's just NOVA. But everything is an acronym now in cardiology, but not NOVA. They pointed out that they looked at our own data. I mean, they're from Brazil, and they looked at our NHANES data and said, let's look at men and women, how much ultra-processed foods, which is the top line, the purple line. You can see it's been going up, and this is pre-COVID, which went up even more. And the question is, why does it go up? What are we eating more ultra-processed foods for, and what are we not eating in its place? Well, the processed foods are in orange, the processed culinary ingredients are in green, and these aren't too bad, but the minimally processed fruits, or foods, that's like the fruits, the vegetables, the legumes, the whole grains, that's what we're eating less of. And so the difference, we're eating more ultra-processed food at the expense of minimally processed food, which really tells you a lot, because it's the one thing we should eat more of, and we're actually eating less, and we're replacing it with something that's really bad for us. So foods you do not realize are ultra-processed. And I know everybody in this room, if I were to ask you one-on-one, doctor, I never eat ultra-processed foods. I mean, I don't touch them, ever. Well, then you're the one person in the United States that, it's like the patient says, doctor, I could sit there and look at a piece of pie and I will gain weight. You know, I eat cardboard and alfalfa sprouts and I still gain weight. Then you're the one person that happens to. It's interesting, we see a lot of patients from California, actually Hollywood. In the Hollywood people that have lost weight for movie roles, it's incredible. They'll come and say, oh, I got this diet, I follow this diet, and the person that gave me the diet, there's a person in Hollywood that does this, told them exactly how much weight they would lose over about 6 months. Exactly, if they just follow the diet. But no one follows the diet. What can you do? Plant-based milks. You know, the milk industry is really mad they let the word milk be applied to, you know, almond milk and soy milk and all these things. And now the meat companies are going through the same issues. But you can see there's a lot of emulsifiers in the plant-based milks. There's gums, there's flavors. The emulsifiers are really bad because they bother our microbiome. The meal-based sauces, they have a lot of things in them. Salad dressings are the worst. Look at ketchup, half of it is sugar. And you eat some regular ketchup real ketchup that doesn't have sugar, and it tastes weird. And you almost go back to, you think, oh, where's the other stuff with all the sugar in it? Fruit-flavored yogurts. I mean, I saw some today, and I'm sure those were organic and had nothing in them. Protein balls and muesli. Our son, who is in training, and he buys all these bars. And he said, oh, God, Dad, they're organic. They're great. I said, let me kind of just look at one of them. And I looked at it and said, you know, Ben, these things are organic, but this is organic high fructose corn syrup. I mean, that's and then nuts and seeds. And there's going to be a big thing from the American College and American Heart coming out on seed oils. Seed oils are really bad. Not the safflower, not the sunflower, not the corn oil itself, but it's how they process it. Safflower, or actually canola, which is not, that's a name they made up, Canadian oil, it's a rapeseed, and they wanted to change the name away from rapeseed, but it is filtered with hexane. Hexane is what we used in Texas to filter oil that came out of the ground when I was growing up. And it's something that there's a allowable limit of hexane in the canola oil, or the safflower oil, or the sunflower oil that you buy at the store. So these things really are, you need to start trying to figure out what this is you're getting, what you're eating. The other thing is artificial sweeteners, and this is starting to percolate up. It's been 25 years ago that artificial sweeteners, specifically the alcohol, erythritol, and sorbitol, increased platelet aggregation. So that's not anything new. But then they looked at some databases and found it increased cardiovascular adverse events at commonly achieved levels in both the US and Europe. And the cardiovascular MACE rate, hazard ratio was like 1.8, 2.2, and that's pretty significant. And it certainly, recently a study showed the MACE goes up with women too that use erythritol especially. Now, where are these found? They're found in sugar-free products, diet, soft drinks, baked goods, very hard to find. So one thing that I think is very interesting, anytime you're looking at foods that are allowed in this country, you say, what does Europe allow? Europe does not allow erythritol in drinks. They'll allow it in baked goods and in hard goods, but not in drinks. And so you have to be careful because this will clearly, looks like increase your risk for cardiovascular disease. So what do I do? What I recommend patients do, get Yucca. Yucca is a phone app. It started in Europe. It had, last time I checked, about 80 million subscribers. It's free. And you can aim at the barcode, and it will tell you instantly when you buy something, it has to have a barcode on it, what's in it. And it will tell you a lot of things that you don't know what they are, and if you can't pronounce them, you know what to do about that. Put them back on the shelf. My wife and I will play a game where we go to the store and go to the children's cereal section and try to find the lowest score we can find, and it's not hard. The multi-sugar, frozen, or coated whatever cereal, those have scores of 0. That means there's nothing good. And once our kids start eating them at age 3 to 5, they can't stop the rest of their life. So the Yucca app, I think, is really a great option because you can start to control what you eat. So be very intentional about what you eat, about what you put in your mouth. Try to switch an unhealthy food to a healthy food daily. And over the years, that will lower major adverse cardiovascular events, as shown here. This was a study replacing one serving of refined grains with fruit or vegetables or low-fat dairy. And you can see you lower your MACE about 10%, 8 to 10%. And this is over years, obviously, but it has to be intentional, what you do. And these ultra-processed grains and such and highly processed grains are very difficult on our body. What if you replace 3% of red meat protein with plant protein? And this is really true for the ultra-processed red meats. There are very few things I tell patients not to eat. You know, you can't tell patients, don't eat this. You better say, oh, eat more of that. But the one thing I tell them don't eat is don't eat ultra-processed red meat. And that, unfortunately, includes a lot of things that come by us every day. Bacon. If you grow the pig, you slaughter the pig, you cook the bacon, that's one thing. But look at any bacon. Almost every bacon has applewood smoked or has some other things added to it. Sausages, anything that's ground up. If you eat a hamburger that you control the steer, that's pretty good. But if you eat a hamburger in a store or in a restaurant, you don't really know what's in it. And there's a lot of things they put in those, so you got to be careful. But if you can switch any of this processed meat for a plant protein, for instance, that on a regular basis after years will lower your risk of MI almost 40%. Unprocessed red meat, that's the processed. Eggs, you know, eggs are not that bad, but you got to remember that if you eat too many of them, and 75% of people in this country that eat more than the allowed allotment of cholesterol per day is due to egg yolks. Egg whites are great. Egg yolks have a lot of cholesterol in them, and you can get in trouble. It's more beneficial to avoid some of these things if you have other risk factors, like if you're a smoker, have a lot of alcohol intake, if you're overweight or inactive. These risk factors multiply each other. They don't really just add to each other, as you probably know. So even small changes here can really make a difference. But it takes years. It's years of doing this. And I don't think this is self-control. I don't think this is willpower. I think this is really habits. Because everything we do is pretty much a habit. You look at your daily life, how you drive to work, or where you go to the store, or what shows you watch on TV. It's all pretty much a habit. You have to replace one habit with another, because your brain loves habits, because it can do something else while you're doing a habit. You can drive to work and never even think about it. And we have a 1-hour commute almost every day. And my wife has been gone because of a new grandchild. And I'll drive to work and listen to podcasts or think of things. I'll get to work and think, my God, did I hit somebody on the way in? I'll go out to the parking lot and check my bumper to see if there's not some hair or something on it. I don't remember a thing about it because your habits are so ingrained in us. Take in a little more fiber, and that's what these ultra-processed foods don't give us, is fiber. Another good name for fiber, a way to think about it, is it's a non-caloric carbohydrate. So is fiber intake associated with primary prevention of fatal or non-fatal MI? Yes, it is. As you can see here, that our current intake of fiber is about 18 grams a day. Recommended, it's about 30. Our ancestors ate 90 to 100 grams of fiber a day. And if you look at the Samana Indians who are in the Bolivian Amazonian rainforest and have been called the healthiest hearts in the world by age, by the Lancet, with the CT scan study, they eat like they did 20,000 years ago, and they eat about 60 or 80 grams of fiber a day, but it comes off a tree or a bush or a vine. So if you can eat more fiber, you can see that the relative risk for heart disease goes down. And it has to be really a soluble viscous fiber, which comes out of plants. If you want supplements, you can take in the two main ones are oat bran and psyllium. Those are the viscous fibers. But this was a study of 200,000 patients over 3 years in 23 different studies. So clearly eating some fiber will help. So how do you do that? How is it easy to do? Well, this is a list of 7 grams of fiber per 100 calories. They'll lower your cardiovascular risk 9%. So at Mayo, they give us little bags of carrots. Isn't that nice of them? We joke about it at Mayo, but we go down to our break room, where I work in a building that has 3,000 doctors, and we go down and we get coffee, and we get free drinks and tea and such, and we get little bags of carrots. They don't give us red kidney beans, but those would be good. Raspberries, Brussels sprouts, the cruciferous vegetables are great. The fruits, the vegetables, the fruits are on the right. Those are great. So when you pack your kid's lunch, what does the mother do for you? She puts little carrots in a Ziploc bag when you're little, or puts in slices of apple or pear or something like that. And that's really a great idea, and that's something that we all need to do more of, but we get too busy. So be smart about physical activity. And, this is a point, I think, to bring up this idea that, what Dr. O'Keefe talked about is great, and the GLP-1s are fantastic, the SGLT2s, and there are more and more coming. But remember, those are all in addition to lifestyle. And we've known from other medicines, like statins, if you don't eat healthy, Salim Yusuf did a great study once where he did a simvastatin study for approval by the FDA. Salim is in Canada, was at McMaster, and he asked one question. Say, how do you eat on this scale of Mediterranean diet? And he showed that if you ate in the bottom 40% of Mediterranean diet, not Mediterranean, in the simvastatin study, your LDL came down, but your heart attack and heart failure rate did not change. So it's not just about the pill, it's also about the lifestyle. So be smart about physical activity, because your muscles don't know what year they were born. If you tell them to exercise, they will do it. And so how much does improving your fitness decrease your risk? You can reduce cardiac mortality 11% for every 1 MET you can do of exercise more. In 1 MET, everybody's using 1 MET now, sitting in a chair. You do a treadmill, Bruce protocol, people get up to 10 to 12 METs, something like that. And so it's really important to try to increase your fitness. Well, so what do the guidelines say? Go to the gym 45 minutes, 3 days a week. Anybody in this room have 45 minutes, 3 days a week? I've not met that animal anywhere in the last 5 years since COVID. So we encourage a lot of interval activity. This is from the handout. The most common exercise handout we give out at Mayo is interval activity. And intervals are what we used to do. Our species never got up in the morning and turned to our significant other in the cave and said, honey, I'm going to jog for an hour and bring you a latte on the way home. You would say, I'm going to leave the cave, try to find some food, not be killed. And something would chase you. It wouldn't need to chase you very long to catch you. And there's nothing we can chase that we can catch up to except maybe a turtle that we want to eat. But a bunny can outrun us very quickly. So we would do short intervals in between periods of walking. So what we encourage here, and we pick 2 minutes as the maximum interval, because that will, there was an article in circulation about 12 years ago that showed that even with EFs of 20% due to ischemic cardiomyopathy, people can do 2 minutes of intense activity without having dysrhythmias or problems. So we encourage, once you warm up, go very hard on the relative perceived exertion scale. It goes up to 20 is the hardest work you can do. Do that for a couple of minutes or less, and then slow down and get your breath back. And that sets up all the things that Dr. O'Keefe talked about, the autophagy. It changes, it looks at, the autophagy will look at not just the mitochondria, also your genetic mutations. That's the reason exercise reduces cancers. It also will look at any other abnormalities like proteins that are abnormal. You'll either delete them or fix them, and that's why it reduces Alzheimer's. So accelerometer studies have shown that very vigorous physical activity, like I just talked to you about, will reduce heart disease and cancer. 2 bouts a day, less than 2 minutes, will reduce cardiovascular mortality 35%. Now, I'm not saying that's adequate, but 2 minutes of intervals like we talked about. And so one thing I love to do is run up the stairs when I go down to the break room. I'm on the 5th floor of our building. I run back up. You do 3 stairs per second, and that's a much faster pace than you're used to going upstairs. But that's been shown to increase your cardiovascular fitness within 6 weeks by 1 MET, and it also lowers your overall cardiovascular risk. The only problem I had with it was when I walk into a patient's room, one patient said, "Doctor, you're so red in the face, do you need to lay down on the..." So I had to get in better shape before I could keep doing that regularly. And if you look at a different database here, the vigorous physical activity in minutes per week, and the red line, the vertical red line, is 21 minutes a week that we talked about. This is 3 minutes, 7 days a week. 3 intervals followed by 30 seconds of downtime to get your breath back. Reduces all-cause mortality, cardiovascular disease, and cancers. And the interesting thing here is that you can say, well, I can get that much benefit with just 21 minutes. Why don't I start running marathons? And that will help you more, but you can see that the curve starts to flatten out. And so just do what you can. And some days I will use my wife's Peloton when I'm working from home. And she got a Peloton during COVID. And I will get on it and I will warm up for 2 seconds and go hard for 2 seconds or longer if I have time. Marty Gabala in Canada found that actually improves your metabolome going just those short periods. So it looks like I need to start finishing up here. Before Dr. Khan gets the hook. The last thing I want to mention is what's the worst emotion for your heart? Pessimism, where you think things are going to be bad. Not fear, but pessimism. So what you can do is practice good thinking, optimistic thinking. A minimum goal of writing down 3 good things that happened, or just think of them. And then say to someone else, when they say something good to you, give them a positive comment. Too much we're trying to one-up everybody else. But that showed that reduced cardiovascular MACE by 27% after 5 years of follow-up in almost 8,000 patients. So be positive every day that you can, and it can be little things that you're positive about. The final slide, after 50 years of reduction of cardiovascular death, it's rampant again. We need to do something. It's driven by lifestyle. 90% of U.S. adults are at risk, and 50% have disease. Spending more on money may not necessarily help it. Many adults do not feel they need to change, and the changes must be incorporated into your daily routine or into your daily habits. And finally, the best answer is small change and probably a little bit of GLP-1 agonist. Okay, thank you. Sorry.